Now, you've all heard, I think you've heard, that the eyes are the window to the soul. But we also know that the health of the soul is seen through the eyes. And so consider these expressions. There was fear in her eyes. His eyes lit up with happiness. You could see the joy in her eyes. And so what we do is to do our best to deal with diseases that affect the structures around the eyes, because we realize what an impact it has on our patients, and we deal with a huge number of types of diseases around the eyes. We are the British Oculoplastic Surgical Society. We are lucky that our founder, Professor Richard Collin, is here today. We are, if you like, a group doing our best to wrest away from the general plastic surgeons diseases around the eyes and the eyelids and to cure them and to treat them. But what I would like to do, though, is to ask our secretary, who's come to give us a few words on what we do and why we exist at all. Thanks. So that Carole Jones has very kindly come in to say a few words, and then I'll carry on. Thank you, Carole.
Thank you. No, I'm sensitive to the time, and thank you very much, so many of you, for staying. The Oculoplastics Society formed in 2000, and the committee are listed here. We have 130 members. These are full members who are fully qualified oculoplastic surgeons, and we've got a number of trainees and associates. But what is even more significant is that our annual general meetings, we have on average 300 delegates, and that's from across the UK and from Europe. What is oculoplastic surgery? We're the specialists that have got particular expertise in the area around the eyes, as David alluded to, the eyelids, the orbit, the lacrimal drainage system, and in some cases the upper and mid-face. The society was formed to advance research, education, and the quality of clinical practice. We're a relatively new society. We formed in the year 2000. Richard Collin was, in many ways, the forefather of the whole society. He was one of the organising committee that inaugurated the society. We already do a great deal of research. We have a publication prize and we have a research prize. We're very excited to be part of NFORC. We believe we're the O in NFORC, but we're keen to capitalise on the great joy of being able to obtain big data sets that will allow us to do even more significant research. Thank you.
Thanks very much indeed. Well, melanoma of the eye, we're looking at a very rare disease. It's life-threatening. You wouldn't believe that a small lesion around an eyelid could kill you, but it can. And it can lead to blindness. The surgery is destructive, as one of our patients will attest to in a moment. Excision is no guarantee of a cure. Even if you excise the lesion, the patients can still have disease elsewhere. Antibody therapy is available, but who should we give it to? And what is indeed the best treatment? There are various kinds of melanoma, and I'm not going to bore you with every single type, but effectively you can either have melanoma on the eyelids themselves. Here you see a couple of examples, and they can present in a myriad of different ways. They don't come with labels on, and just as you've heard with tumours in the mouth, they're very difficult sometimes to spot. Even experienced clinicians can be caught out occasionally. And the problem is that although treatment is surgery, secondary spread can still occur, even if it's completely excised, and therein lies the problem. Disease spreads peripherally to the liver, for example. Melanoma can occur on the eye, even rarer, but even more lethal, even more dangerous, because you see the 5-year mortality is approaching 1 in 3 patients with a very, very poor prognosis. Here you see one similar such patient that we've been managing. You can get melanoma, for example, inside the eye, even more worrisome, really, because it can go unnoticed for some time until the patient comes to you to say that they have problems with their vision. I remember very well seeing a 24-year-old lady who had an advanced melanoma who had the eye removed only days later. Disfiguring surgery, which does not offer a guarantee of a cure, unfortunately. And you see the survival rates are not very good, are they? 10 years later, a third of the patients have died. Melanoma is a killer, and we don't really quite know always how best to treat it. Then, of course, you have melanoma around the eyeball, and that's an area that I specialize in as well. Here you'll see a patient in real life in about 35 seconds or so. This gentleman presenting with a very unusual melanoma right behind the eyeball, as you see here. In his case, it never had existed elsewhere, but if a patient did have disease elsewhere, and they then pitch up with disease around the eye, this graph is telling you that if all of them are still alive on day 1, come 1 year, 50% of them have died. If we knew which of those patients would respond to various antibodies, we might be able to select them out early on. Because monoclonal antibodies do offer some hope. I'm not going to go into it in great detail, but the idea is that we can either quieten down or awaken the immune system such that the correct cells die off. And the problem is who should receive such treatment. Here you see one such patient. This poor gentleman had melanoma of the eyelid. We removed it. We reconstructed the lid. That's him after the reconstruction. I was rather glad that I thought I'd done a good job. But in fact, I hadn't. Nature was one step ahead of me. The lesions came back into the lid here. This patient was put on a monoclonal antibody called ipilimumab. And here he is, you see him only a week or 2 ago, and we're looking at the lesions in his lid to gauge how well this antibody is treating the rest of his body, which we know has disease. But if we only knew which patients would respond and which patients didn't respond, then we might be able to select the patients more effectively. And that's the point of collecting enough data across the nation, not one hospital versus another hospital. It's nationwide, and that's why this group has come to being. And that's why we as oculoplastic surgeons feel that we have something to contribute and are extremely glad to have been invited to be on board. So melanoma of the eye, as you've seen briefly, is life-threatening despite adequate excision. Surgery is highly disfiguring at times, as you're about to find out. We do have specialized antibodies, but we still don't know who's going to respond and who will have the side effects to these very expensive antibodies that can also increase the risk of other tumors elsewhere. And we know that the more data that we have, prospective data, the more we're likely to find out which patients have a better or worse prognosis, and that can't really be done by one institution collecting rare numbers of diseases and describing their last 10 cases. It simply cannot be done. So it's time, now that we live in a global village, to get together the data constructively between maxillofacial surgeons, eyelid surgeons. Together, we have to have this cross-fertilization. That's what NFORC is about, to improve the outlook for patients, maybe not in my generation, but perhaps in our children's generation, and we do owe it to them, and my children's generation. And so, in the past, if you like, we will look back and we will say that this is probably not going to show, we were dinosaurs in a sense in terms of the way we behaved. And in fact, and it's sad to show, like many other speakers, I spent some time doing this, but it's not going to show. But the point is that the future is going to look like the Starship Enterprise, which I couldn't show you there. And it's only going to get there, not by chance, but by having enough data sets to decide which patients benefit from which treatment. And that's why I think oculoplastic surgeons need to be on board, because we can offer those data sets around for these rare diseases that affect the eyelids, the eyeball, and around the eye. But you've heard enough from me. The reason that I'm standing here and that Ian's invited me is that we had a common patient, Joshua. I'll introduce you to Joshua. Is now, like many patients, they become a friend after a while, and the distinctions become blurred and irrelevant anyhow. And Joshua really presented first to Professor Richard Collin, who actually was responsible for getting him on the right track, which was a biopsy, and the rest is Joshua's history, which he's going to tell you. So could you tell us why you're here and what's happened to you? And it's far better that you tell them than I summarize it. Thank you, Joshua.
Hello, everybody. I'm just here to tell you a little bit about what happened. Back in 2009, I had something like an irritation in my eye, like an allergy. I went to see an optician, and I was told that I had blepharophthitis, so I was using Johnson's baby shampoo. Unfortunately, that didn't work, and I later on realized that my eye was beginning to protrude a little bit. Anyway, I then went to see, very fortunately, David Verity, who that very same day did a CT scan and discovered the mass behind my eye. 2 weeks later, I went on to have a biopsy. Unfortunately, the biopsy showed I had malignant melanoma. I then went on, a few weeks later, I went to see an oncologist at Barts, who then recommended that I went through 6 weeks of radiotherapy. I had this mask made. I believe perhaps if NFORC had existed back in those days, then it might have been evident that radiotherapy actually wouldn't have cured my melanoma. So I went from, I haven't got any modern technology here, I've just got some photographs, so there won't be any technical problems. I have a photo of me, this is me. This is me back in May 2009, I believe just looking very normal. You couldn't see, there was no sign of any problems whatsoever. This is me, thank you. This is me just a few months later when I was actually having the radiotherapy treatment, and you can see the radiotherapy. You can actually see it was like a square that was being treated. And during that time, it was quite evident that the melanoma, I've kind of felt it myself, it was just protruding even more instead of retreating? Yeah, protruding. So wearing that tight mask, I could feel it getting tighter and tighter, and it was over 6 weeks. It was 5 days of the 6 weeks, 5 days a week. So at the end of the 6 weeks, I ended up in this state here. I was then told that I would have to have an extrusion of my eye, and I'd be left with a hole in my face. I guess at that point I was very fortunate to be introduced to Professor Hutchinson, Ian, who reassured me that he would do the best he possibly could do. So I had a free flap taken from my thigh. So I had this area here all removed, and it was placed into my eye, where my eye would have been. So I ended up looking like that. It was almost like an orange had been put on the front of my face. The skin, it just seemed very weird because the hair was growing almost immediately when it was transplanted onto me, or when it was placed there. Unfortunately, then shortly afterwards, I think it was about 3 months, I was told that it had actually gone into my upper jaw and the roof of my mouth on the left-hand side. So this was the night before that surgery, and these two photos show very clearly, you could see here, one side of my face looking totally normal, and the other side you can see very clearly the problem that was existing. So I then went on to have a part of my shoulder blade removed and placed where my jaw was. So I went through all that procedure there and all the exercises that you have to do and everything. And I was very fortunate because during this process I had not just one but two surgeons working on me. I had David Verity from Moorfields and Professor Hutchinson from Barts, and I believe that's one of the first time that's happened because they had to get a special license to work together. So then, after that, I then was very fortunate because Andrew Darwood got involved, who's just sitting in the front there. Hello, Andrew. My dentist. He did a 3D model of my skull, and this is what I had rather a lot taken away with the cancer. So this section here shows my shoulder blade and where the implants were put into. I've had quite a lot of operations, and not very flattering, but this is how I looked after that surgery. You can see all my face is totally distorted here. I guess the weight of the leg muscle being put in my face dragged my face down, and my nose and everything was distorted. Later on, I went on to have more operations, very fortunately involving Andrew as well, who put in the implants into my face, and actually into the shoulder blade. And you can see with these two photos here, I was then had my first eyeball put in, but you can see my face is very distorted still. It's not a great look, but I had the beginnings of something that was actually better than just having a hole in my face, which I was originally told. Unfortunately, later on, I went on to have a metastasis, and I had liver surgery. And very fortunately, that had been there ever since I was being scanned, and it was growing very, very slowly. So fortunately, that was removed with a clear margin. I've gone on to have further operations. I had my last one just a month ago. Yeah, 5 weeks ago, 6 weeks ago, something like that. And I had some fat taken from my leg and put into my face because this was very sunken in here. I'm very fortunate that I've got the kind of hair that can disguise my disfigurement a lot, and I wear glasses a lot, and this is kind of just showing that life goes on and that you can still have a good time with disfigurement. And yeah, I would hope that it would encourage other people that you can carry on living with malignant melanoma. What I can do now, I wear these as to disguise and cover up, but if I show you, this makes it much clearer what's still going on there. There's, as far as I'm concerned, there's still a lot of work to do. I've got this section here which really disturbs me because I can't smile. If I smile, this is me smiling. And then I end up with this blob here. So hopefully in the future, there'll be some technique to be able to raise this. I don't know, with NFORC, hopefully, there will be a lot more people in my situation that will benefit from a whole culmination of the whole world just getting the benefit from everybody's information being put together in one spot. Okay?
And all I would say is, look how much we've learnt from one patient, only one patient. So there's a lot more to learn when we coalesce and we get our information together. Thanks very much, Joshua, for having the courage to come up and talk about that.